Diabetes mellitus. Definition: it's a chronic metabolic disease in which there is an error of carbohydrate metabolism due to absolute or relative insulin deficiency, ending in chronic hyperglycemia, glucosuria, vasculopathy, neuropathy, disturbed fat and protein metabolism. Egypt in the world's top 10 in terms of highest number of people with diabetes. Etiology: primary includes 3 types: type A, type 2, special types such as Moody and Dada. Type 1, previously called insulin-dependent diabetes mellitus or juvenile onset diabetes mellitus. Type 2, previously called non-insulin dependent diabetes mellitus or adult onset diabetes mellitus. Special types: Moody, mature onset diabetes in young patient, monogenic, single gene mutation. It's occurring in patients under the age of 25 with strong family history. It was classified as a subtype of type 2 diabetes, but it's now a separate entity due to genetic research. It doesn't always require insulin treatment. It's due to a single gene defect with autosomal dominant mode of inheritance. There are 6 variants, 1, 2, 3, 4, 5, 6, due to different gene mutation, all of which limit the ability of pancreas to produce insulin. LADA, latent autoimmune diabetes of adult, a condition in which type 1 diabetes develops in adults. Here, the autoimmune beta cell destruction is slow, so it's frequently initially misdiagnosed as type 2 diabetes. The old classification of insulin dependent and non-insulin dependent is misleading because many patients with type 2 diabetes require insulin in their treatment. Secondary: pancreatic causes, endocrinal, drugs, genetic syndromes, and others. Pancreatic causes: any disease diffusely injures the pancreas, such as chronic pancreatitis, cystic fibrosis, hemochromatosis. Endocrinal: Cushing, glucagonoma, acromegaly, pheochromocytoma. Drugs: beta agonist, cortisone, thiazide, contraceptive pills. Genetic syndrome, sometimes associated with diabetes: Turner syndrome, myotonia dystrophy, Down syndrome, Friedreich's ataxia. Others: gestational diabetes, rubella, cytomegalovirus, Coxsackie virus, and Dead-Moat syndrome. Pathogenesis: type 1, 15 or 10%, autoimmune destruction of pancreatic beta cells leading to absolute insulin deficiency. The genetic factor play an important role. The combination of HALA DR3 and DR4 makes a person more likely to develop type 1 diabetes mellitus. Viral infection may also play a role. Without insulin, those patients are prone to develop ketoacidosis. Also, typically diagnosed before the age of 30, they can present at any age due to variability in rate of beta cell destruction. Peak incidence is at age 12 years. Type 2, 85%, is characterized by peripheral insulin resistance, so hyperglycemia develops despite above average level of insulin. In addition, it may be due to abnormal structure of insulin or due to anti-insulin hormones such as glucagones. Factors play a role in pathogenesis include genetic predisposition and obesity. So if we're going to compare between type 1 and type 2 diabetes mellitus, according to incidence, type 1 10%, while type 2 90%. Pathogenesis: type 1 insulin deficiency due to damage of beta cells, type 2 insulin resistance. Insulin level in type 1 is decreased, while in type 2 is normal or even high. Age of onset is young in type 1, below 30 years, while in type 2 it's above 30. Body weight in type 1 thin, in type 2 obese. HALA association in type 1, HALA DR3 and 4, while in type 2 there is no HALA association. Hereditary factors in type 1, 30% in identical twins, no family history. When both parents are affected, there is 10% risk for the child to develop type 1 diabetes mellitus, while in type 2, near 100% in identical twins, strong family history, and when both parents are affected, from 70 to 100%, the child will develop type 2 diabetes mellitus. Clinical picture for type 1, it's severe with ketoacidosis commonly occurring, and the complications are more common than type 2. Autoantibodies: islet cell antibody, ICA, and GAD, glutamic acid decarboxylase antibody. Type 2, we have mild to moderate severity. Ketoacidosis is rare, but when it occurs, it needs precipitating factors, and complications are less common. There is no association with antibodies. Treatment for type 1, oral hypoglycemics are ineffective. Insulin is the optimal treatment, while type 2, oral hypoglycemics can be effective, and insulin is used in severe cases. Then we have stages of diabetes mellitus: pre-diabetics, latent, chemical, clinical. Pre-diabetics, IFG or IGT. IFG means impaired fasting glucose, or IGT, impaired glucose tolerance, depending on the test used to diagnose it. It's a condition in which blood glucose levels are higher than normal, but they are not high enough for diagnosis. It's an intermediate category between normal and diabetes. There is a risk for future diabetes and cardiovascular diseases. Criteria for diagnosis: fasting glucose from 100 to 125 milligram percentage, glucose tolerance 140 to 199, hemoglobin A1C 5.7 to 6.4. Prognosis: IGT leads to type 2 diabetes mellitus in about 34% cases over 5 years, while IGT and IFG lead to type 2 diabetes mellitus in 65% of the cases. Pre-diabetics are at high risk for cardiovascular complications. This group includes positive family history, obesity, females with bad obstetric history, macrosomia, renal glucosuria. Latent diabetes: it appears only on exposure to stress and disappears after removal of stress, such as pregnancy. Chemical diabetes: raised blood glucose without symptoms. Clinical diabetes: uncomplicated and complicated. Complicated may be the first presentation. Uncomplicated, we have the classic triad of symptoms, 3 Ps: polyuria due to osmotic diuresis induced by sugar, polydipsia due to loss of fluid, polyphagia with weight loss. Decreased insulin will lead to no entry of glucose to the satiety center. So the loss of weight is due to fluid depletion, fat and muscle breakdown. Investigations of diabetes mellitus: we have blood and urine, monitoring of treatment, investigations for the complications, investigations for the cause, and investigations to diagnose type 1 diabetes mellitus. Investigations for the cause are the investigations for secondary diabetes. Investigations to diagnose type 1 diabetes mellitus include C-peptide and autoantibodies. There are four autoantibodies which are markers for beta cell autoimmunity. In type 1 diabetes mellitus, one or more are present in about 90% of the cases, and the most common are ICA and GAD. ICA, islet cell antibodies; GAD, glutamic acid decarboxylase; and then we have insulin autoantibodies and protein tyrosine phosphatase antibodies. C-peptide, short 31 amino acid polypeptide which connects insulin A chain to its B chain in the pro-insulin molecule. C-peptide levels are measured instead of insulin levels because C-peptide can assess person's own insulin secretion even if they receive insulin injections. Very low level of C-peptide with high blood glucose level is found in type 1 diabetes mellitus. Then we have investigations for complications: plasma lipids, KEFT and LEFT, but more commonly KEFT, renal function test, urine analysis, serum creatinine, electrolytes, and imaging, chest x-ray, ECG, echo, duplex, and carotid, lower limb. Then we have monitoring for treatment: plasma glucose monitoring and glucosylated hemoglobin, hemoglobin A1C. Normally it's less than 5.5 of the total hemoglobin, but if it's 6.5 or more, then this means diabetes. If it's from 5.7 to 6.4, this is pre-diabetes. If it's more than 12%, this means poor glycemic control in the past 3 months. And then we have urine, glucosuria, ketonuria. Glucosuria occurs when glucose serum level exceeds 180 mg/%, which is the renal threshold. It's not a very good indicator for diabetes diagnosis. Ketonuria for diagnosis of diabetic ketoacidosis. Then we have blood sugar tests: fasting blood glucose and 2-hour postprandial. Fasting blood glucose, no caloric intake for at least 8 hours, normally from 70 to 110 mg/%. If it's 126 mg/% or more, then this means diabetes. And if it's from 110 to 125 mg/%, this means impaired fasting glucose, pre-diabetic. 2-hour postprandial, normal, is less than 140 mg/%. If it's from 140 to 199 mg/%, this means impaired glucose tolerance or pre-diabetics. If it's 200 mg/% or more, this means diabetic. To convert millimole per liter of glucose to milligram per deciliter, you need to multiply by 18. Then we have oral glucose tolerance test and cortisone glucose tolerance test. Cortisone glucose tolerance test: dexamethasone 3 mg given before oral glucose tolerance test. This induces hyperglycemia in latent and pre-diabetics. Oral glucose tolerance test. Patient should be fasting overnight. Fasting blood sugar is done. Then the patient drinks glucose solution containing 75 grams of glucose within 4 minutes, according to the WHO criteria. Then we take blood samples every half an hour for 2 to 3 hours. The normal curve is characterized by 3 criteria. The fasting level is from 70 to 110 milligram percentage. It reaches its maximal point in 1 hour, but it's still under 180 milligram percentage and returns to normal within 2 hours. And this concludes the investigations. Then we have the diagnostic criteria for diabetes according to the American Diabetes Association. We have hemoglobin A1C 6.5 or more, fasting blood glucose of 126 milligram per deciliter or more in 2 separate occasions, classic symptoms of hyperglycemia 3 Ps plus random glucose of more than 200 milligram per deciliter, 2 hours postprandial glucose of 200 milligram per deciliter or more, confirming the presence of diabetes. Then we have the pathogenesis of diabetic complications, recurrent infections, glycosylation of blood vessels, and biochemical or accumulation of sorbitol. Recurrent infections, not only common but very severe due to impaired polymorphonuclear functions, due to impaired leukocyte migration and phagocytosis, decrease in the antioxidant activities, and acidosis which inhibits antibodies production. Glycosylation of blood vessels, this leads to thickness of basement membrane of capillaries, narrowing their lumen, vasculopathy, leading to micro and macroangiopathy, and the most important and the most dangerous one is microangiopathy. Biochemical or accumulation of sorbitol, glucose is reduced to sorbitol by aldose reductase, leading to decrease in the ATPase activity, leading to neuropathy and nephropathy. Then we have complications of diabetes mellitus. This is a very important part of the chapter. Cutaneous. We have infections, carbuncles, recurrent abscesses, fungal infections, especially in the anogenital region and interdigitalis, pruritus, especially pruritus valvi due to monilial infection, delayed healing of wounds, bacillasma due to hyperlipidemia, necrobiosis lipodica, diabetocorum, red, painless papules with yellow center, usually over the anterior surface of the legs, cause cutaneous blood vessels occlusion. Then, cutaneous features of diabetic foot, acanthosis nigricans, black patches due to insulin spillover into the skin in type 2 diabetes, excess insulin, this is very MCQ note, lipodystrophy at the sites of insulin injection. Cardiovascular. We have 4 points: microangiopathy, macroangiopathy, cardiomyopathy, blood pressure. Microangiopathy leads to diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. Macroangiopathy or atherosclerosis leads to cerebral system thrombosis ischemia, coronary angina myocardial infarction, and painless myocardial infarction due to neuropathy. Peripheral gangrene, intermittent claudication, renal, renovascular hypertension. Cardiomyopathy due to microangiopathy. And finally, blood pressure, systemic hypertension, and postural hypotension due to autonomic neuropathy. Causes of hypertension in diabetic patient: diabetic nephropathy, endothelial dysfunction, insulin leading to retention of sodium, secondary diabetes from Cushing and acromegaly, or type 2 diabetes may be part of metabolic syndrome X, which consists of diabetes, hypertension, hyperlipidemia, and obesity. Chest. Recurrent chest infection, TB, because TB follows diabetes as its shadow, rapid, deep respiration, cosmal respiration, and acetone smell in DKA. Then we have gastrointestinal. Diabetics never have normal bowel habits. For mouse, we have gingivitis and losing teeth. Stomach, gastroparesis, nausea and vomiting, abdominal pain in DKA. Intestine, diarrhea due to autonomic neuropathy, bacterial overgrowth, celiac disease, and drugs such as metformin and incretins. Then we have constipation due to vagal neuropathy. Liver, we have fatty liver, chronic cholecystitis, and gallstones. Gentle. In males, impotence, psychological neuropathy, and vasculopathy. In females, we have infections and pruritus vulvi. Effects of diabetes on pregnancy. On mother, we have eclampsia, postpartum hemorrhage, puerperal sepsis. On fetus, we have high birth weight, hypoglycemic baby, congenital anomalies. Effects of pregnancy on diabetes: increases the need for insulin due to increased anti-insulin hormones such as estrogen, decreases renal threshold for glucose, and increases incidence of complications. Eye: LEDs, infections such as chalazion, conjunctivitis, and xanthelasma. Iris: new vessels formation, rubeosis iridis. Lens: senile cataract occurring at an earlier age, repeated error of refraction secondary to osmotic lens change with fluctuating glucose level, hyperglycemia leading to myopia, hypoglycemia leading to hypermetropia. Nerves: optic neuritis, cranial nerve palsy, 3 and 4 and 6 nerves. Then we have diabetic retinopathy. It is the most characteristic form of diabetic eye diseases related to duration and control of the disease. Eventually occurs in nearly all patients of type 1 diabetes 20 years after diagnosis. Present in 10% of type 2 diabetics at diagnosis, and in 50% after 10 years of diagnosis, and in 80% after 20 years of diagnosis, usually accompanied by nephropathy and neuropathy. Retinopathy generally occurs first, detected by fluorescein angiography. Pathogenesis: chronic hyperglycemia leading to endothelial dysfunction, accumulation of sorbitol by aldose reductase. Severe ischemia leads to increased cytokines and growth factors such as VEGF, vascular endothelial growth factor. There are two important types: non-proliferative, background retinopathy, and proliferative. The non-proliferative, characterized by hemorrhage, dot and flame, hard exudates, microaneurysm due to damaged endothelium, cotton wool spots, fluffy white patches on the retina due to nerve fibers infarction. During this stage of diabetic retinopathy, no local treatment is needed except in case of diabetic maculopathy. Just good control of diabetes, hypertension, and stop smoking. Then we have the proliferative type, characterized by new vascularization due to increased VEGF, retinal detachment due to fibrosis leading to permanent vision loss, vitreous hemorrhage leading to temporary vision loss. This type must be treated as early as possible by laser photocoagulation. Without treatment, 50% of patients become blind within 5 to 10 years. Proliferative retinopathy is more common in type 1. Diabetic maculopathy is more common in type 2. Treatment of diabetic retinopathy in general: glycemic control, maintain hemoglobin A1C below 7%, blood pressure and lipid control, no smoking, laser photocoagulation, and VEGF inhibitors such as bevacizumab and ranibizumab, and by intravitreal injection. Renal: we have interstitial injury, pyelonephritis, fever, pain, dysuria, and acute necrotizing papillitis, fever, pain, dysuria, and hematuria. Then we have diabetic nephropathy or diabetic glomerulosclerosis. It's a clinical syndrome characterized by increase in urine albumin secretion, increase in blood pressure up to end-stage renal failure with progressive rise in cardiovascular risk. Incidence: in long-standing diabetes, 30% of type 1, 20% of type 2, and the genetic factor may play a role. Pathogenesis: we have three major histological changes occurring in the glomeruli due to metabolic and hemodynamic changes: mesangial expansion, thickening of the glomerular basement membrane, and finally glomerular sclerosis, which is caused by intraglomerular hypertension. Glomerular hyperfiltration leading to proteinuria leading to end stage. In diabetes, we have narrowing in the efferent more than afferent. This will lead to increase in the intraglomerular pressure, leading to escape of proteins that will be taken up by the proximal tubular cells, leading to inflammatory response, scarring, and even fibrosis. The types of nephropathy: nodular, Klippstein-Wilson syndrome, hyaline deposition in one area of the glomerulus, and diffuse glomerular sclerosis, which is global, occurring in hypertension. Clinical picture: long-standing diabetes, especially poorly controlled diabetes, after about 10 to 20 years, rarely develops before 10 duration of the disease. Proteinuria, the early clinical sign of diabetic nephropathy. Microalbuminuria, 30 to 300 mg per day, reversible by ACE inhibitors. Macroproteinuria, more than 300 mg per day, that will progress to end-stage chronic renal failure in 5 to 15 years. Heavy proteinuria, nephrotic syndrome. Lately, progressive loss of renal function, chronic renal failure. Hypertension, diabetic retinopathy, and neuropathy are usually present. In patients with type 1 diabetes mellitus, nephropathy almost always occurs in presence of retinopathy. Stages of diabetic nephropathy: incipient and overt. Incipient includes 3 stages. Stage 1, nephromegaly and increased GFR. Stage 2 is the same as stage 1 plus microalbuminuria on exercise. Stage 3 as stage 2 but persistent microalbuminuria more than 30 mg per day, and this stage may remain silent for up to 10 to 15 years. Then overt nephropathy, stage 4 and stage 5. Stage 4, macroproteinuria more than 300 mg per day, but it rarely exceeds 5 grams per day, decreased GFR and hypertension. Stage 5, end-stage chronic renal failure. Investigations: we have urine analysis. Screening of microalbuminuria is mandatory. It should be performed in type 1 diabetics who had diabetes for more than 5 years and in all type 2 diabetics at the time of diagnosis. Blood, urea and creatinine, ultrasound, normal-sized kidneys with increased echogenicity, not shrunken as usual in chronic renal failure. Biopsy may be done in the diagnosis, but we don't need to do it. Treatment: diabetic control can reverse the microalbuminuria. Control of hypertension is mandatory by ACE inhibitors and ARBs, which decrease the albuminuria even in normotensive patients. Then treatment of chronic renal failure, and you can find this in the kidney book. Then we have diabetic foot. The foot of a diabetic patient has potential risk of pathological consequences, including infection and ulceration. Pathogenesis: neuropathy, vasculopathy, infection produce tissue necrosis. Neuropathy, sensory neuropathy, decrease the awareness of injury to the foot. Motor neuropathy, abnormal motor function of the intrinsic muscles of the foot, lead to deformity, leading to maldistribution of weight. Autonomic neuropathy, decreased sweating, leading to dry, fissured skin and infection. In severe cases, the abnormal distribution of weight on the sole can result in repeated painless fractures and displacement of joints, leading to Charcot joints. Neuroarthropathy, non-infectious, painless destruction of bone and joint associated with neuropathies. Vasculopathy, impaired peripheral circulation. Ischemia will affect the ability to fight infection, as it will make the delivery of antibiotics to the site of infection impaired. Infection: diabetic foot infections are polymicrobial in nature. Lack of wound healing, systemic sepsis, neuropathy, vasculopathy can lead to extensive tissue necrosis and gangrene requiring amputation. Clinical features of diabetic feet: site of ulceration at pressure points, base of big toe, base of fifth metatarsal and heel. We have to compare between neuropathic and ischemic feet. Neuropathic feet are warm, dry, foot pulses are felt, usually painless ulcer with present callus. Ischemic feet, cold with trophic changes, hairless, foot pulses are not felt, more painful with wrist pain and claudications. Wagner classification of diabetic foot includes grade 0, 1, 2, 3, 4, 5. 0 high risk, no ulceration. 1 shallow ulcer, not infected. 2 deep ulcer with cellulitis but no abscess or bone involvement. 3 deep ulcer with bone involvement and abscess formation. 4 localized gangrene. 5 gangrene of the whole foot. Risk factors for foot ulcer or amputation include poor glycemic control and diabetes for more than 10 years, peripheral neuropathy, bony abnormalities and callus, peripheral vascular disease, and previous foot trauma or surgery. Treatment: prevention of foot ulcers and treatment of the infection. Prevention of foot ulcers by podiatric care, foot care, regular visits and examination, patient education, pulse examination, protective shoes, pressure reduction by cushioned insoles, prophylactic surgery to reduce bony prominences. Treatment of diabetic foot infections: wound care by dressing, empiric antibiotic coverage, modified by cultural findings, debridement of necrotic tissue, angioplasty to improve distal circulation. Amputation may be necessary in extensive cases. Diabetic infections: for skin, staph and candida, urinary tract pyelonephritis, perinephric abscess, chest TB and pneumonia, gentle pruritus vulvi, gallbladder cholecystitis. Then we have the life-threatening infections in diabetics: malignant otitis externa, rhinocerebral mucormycosis, emphysematous cholecystitis. It's a severe form of acute cholecystitis characterized by gas production in the gallbladder wall by Clostridium that are often isolated from the bile cultures in addition to other enteric flora. It's frequently associated with gangrene, perforation, and death. Diagnosis involves demonstration of gas within the lumen and the walls of the gallbladder by ultrasound or CT scan. Surgical intervention is necessary in addition to broad-spectrum antibiotics. Rhino-cerebral mucormycosis. It's a life-threatening fungal infection treated by prolonged IV therapy, amphotericin B, with surgical debridement of the involved sinuses. The patient presents with facial or ocular pain, nasal obstruction, followed by proptosis and loss of visual acuity with generalized fahem, fever, malaise, anorexia, headache, and necrotic terminates may be found. Malignant otitis externa, uncommon but potentially life-threatening infection due to Pseudomonas aeruginosa. The patient report history of weeks to months, severe pain, otorrhea, hearing loss. Intense cellulitis is combined with edema in the ear canal. CT and MRI studies are essential for defining the extent of bone and self-tissue involvement. Neurological, we have diabetic macroangiopathy, diabetic neuropathy, diabetic coma. Diabetic macroangiopathy due to atherosclerosis, we have cerebral thrombosis and cerebral hemorrhage. Diabetic neuropathy, pathogenesis unknown, but there are 4 important theories. Hypovitaminosis, as polyuria washes water-soluble B complex. Microangiopathy of the vasa nervosa. Metabolic ketosis, toxic effect of ketone bodies, and transformation of glucose 2-sorbitol by aldose reductase enzyme. Clinical picture may precede the discovery of diabetes. We have mononeuropathy or mononeuropathy multiplex, polyneuropathy, and autonomic neuropathy. Mononeuropathy affect peripheral nerves, femoral, ulnar, median nerve, and diabetic lumbosacral plexopathy, severe deep pain in the thigh with affection of cranial nerves 3, 4, and 6. Polyneuropathy, sensory affection is more than motor. Longest nerves are affected first. Superficial sensation, symmetrical paresthesia, especially in lower limb, followed by stock and glove hypothesia. Deep sensations, nocturnal calf spasm is common. And finally, we have motor weakness, which is late. Autonomic neuropathy. For cardiovascular system, we have postural hypotension, painless myocardial infarction, persistent tachycardia. GIT, we have gastroparesis, delayed gastric emptying, diarrhea, severe nocturnal alternating with constipation. Genitourinary, we have impotence and incontinence. Impotence or incontinence. Skin, we have generalized sweating, edema of the feet due to loss of vasomotor tone, trophic ulcers. Treatment, strict control of diabetes by diet or oral hypoglycemics. Reassurance may be needed. Physiotherapy if motor weakness. Drugs, low benefit, such as cerebrolysine, which is nerve growth factor, aldose reductase inhibitor, sorbenil, vitamin B complex, analgesia for neurotic pain, such as carbamazepine. And then we have diabetic comas. Diabetic comas are hypoglycemic coma, diabetic ketoacidosis, hyperglycemic hyperosmolar non-ketotic coma, diabetic lactic acidosis, and other causes of coma.